Happy Tuesday! How's everybody doing? I am so excited that you're here to join us. Today's guest presenter is Dr. Jeff Lewin, and I'm super excited. I am pretty sure in the decade that we have had the webinar series, I can't believe I'm saying that, a decade. Almost 11 years, guys, that we've been doing this weekly webinar series. I am almost positive that Dr. Lewin has been here before. It's just been a really long time.
It's very long time, but it's great to finally be back with you.
It is so exciting. So if you don't know Dr. Jeff Lewin, many of you probably are thinking, man, this guy looks really familiar because he's phenomenal. He is a certified chiropractic sports physician, a graduate of New York Chiropractic College. I served on the medical staff of numerous athletic competitions, including American volleyball professional tournaments, as well as am I saying this right? The Maccabi game?
Well, Maccabia, but that's good.
Okay. Well, it's a lot for this little Southern girl to say, but on top of that, he's been like a go-to. Y'all know me. I don't know everything, but I know people who know everything. And so he's like my go-to resource and has been since the very early days of my career in chiropractic on everything from documentation, coding, compliance, office policies and procedures. There's like nothing he doesn't know about all of these things. And in fact,
I never say that, because then the universe shows me stuff that I don't know, and sometimes I don't want to know.
Well, here's my philosophy of success is that I don't have to know everything. I just have to surround myself with people who are much smarter than me. And so I do. And I include you in that group of people that I surround myself with. So without further ado, the master of the universe, Dr. Jeff Lewin, take it away.
Well, thank you so much, Christy. It's great to be with everybody today. And I am really excited to share some important information with you all. My goal is to make sure that by the time we finish our webinar today, that you will all have information that you're going to be able to put into practice quite literally as soon as the webinar is done. So if we're able to accomplish that, today will be a success. So quick little overview, like Christy shared with you, I graduated from New York Chiropractic College back in 1989. I've been a Florida licensed chiropractor for 31 years. And in my practice career, I've owned a total of 5 practices. My flagship practice was a multidisciplinary practice where we had chiropractors, I had medical staff, we had physical therapy, massage, acupuncture, podiatry, and even psychology on staff. So it was a really fun, very exciting place. And that I did for myself back in 1995. So if it wasn't the very first multidisciplinary practice, at least here in Florida, it was certainly one of the first. But I've also been a practice management coach for the past 24 years and taking care of doctors all over the US, Canada, and some other countries around the world as well. So I'm really always privileged to have the opportunity to bring that information to my clients and doctors from around the country, so you can take that experience and put it to your good use as well. And most importantly, I like to share with people, I'm not the police. I like to create a nice, safe space. So if you have things that you're doing in your practice, maybe that might not be 100% correct, I'm not going to sit here with judgment. While today we're working from home, some of you that know me have seen me at seminars, and while I might sometimes wear a black suit, I definitely don't wear a black robe. I am not a judge. My entire come from is not to impart fear upon people, but to teach people what they need to know and give you the knowledge and empower you through that knowledge so that you can do the right thing for your practices. We're going to be covering a lot of information today, and it always happens that my slides, while I try not to keep them too text heavy, we do need to cover a lot of information in a relatively short period of time. So if you'd like to have the notes, which is basically a reproduction of every slide that you're going to see here in the webinar, it will be my pleasure to email it to you. So just email me at drjefflewin@gmail.com, and I will send you all of my slides within a few hours after the webinar is concluded. And if you are one of the people who's going to be watching this after the live session, feel free to just mention this webinar as well. and I will send them to you at some point in the future, even if it's weeks or months from now. So getting into the nitty-gritty, let's talk a little bit about us. And we are creatures of habit. Old habits definitely die hard. And it's often been said that the only person who likes to change is a baby with a wet diaper. But sometimes this change is necessary, and whether we like it or not. And we have certainly seen in the past year tons of changes that have taken place in our profession, whether we're talking about during COVID and we had to shift how we were doing things in our office, to all sorts of coding changes. So my goal here is to make sure that you feel the ability to embrace these changes, because your ability to embrace those changes may oftentimes decide who's going to thrive moving forward and who might just survive or wither on the vine and die. Albert Einstein said that the definition of insanity is doing the same old thing, the same old way, expecting to get different results. In healthcare, however, one thing we know for sure is that doing the same thing the same way is not going to get you the same results, but it's going to get you less than those same results. So one example of that is what I like to call MUSH. All right, MUSH is our chiropractic version of insanity, and it's an acronym that for me stands for manipulation, ultrasound, electrical stim, and heat. And chiropractors back in the 70s and 80s built huge, very successful practices built solely upon MUSH. How does that work today? Well, we know if you try to do MUSH today, you're going to get MUSH back for your reimbursement. Doesn't necessarily work too well for us. So we want to make sure that we're staying ahead of the times. The way things were in the 70s and 80s is not the way that we want to do things today. We want to make sure that we carry our practice forward into this new paradigm, knowing how to get the best quality reimbursement that we can. So what I'd like to have you guys consider is to do perhaps a not so little self-check on your own practice. So consider if an auditor, whether it be from an insurance company or a regulatory body, if they were to come in and review the codes that your practice was using during the course of a year, were they going to be happy with what they find? Do you routinely downcode the level of services, thinking that's going to help keep you off the radar? We'll talk about some examples of what that might be. So example might be, do you routinely bill for one type of chiropractic adjustment, one type of CMT, because your philosophy or the number of adjustments performed on a given visit are the certain way? Or do you not perform E&M or exams on a regular basis? These are all things that could trigger an audit from taking place. My goal is to make sure that we minimize the risk of those audits from happening at all. But if we go forward with the expectation that it's not a matter of if, but when an audit happens, that you're going to be able to sail through that audit with flying colors. So we don't want to make sure that we're downcoding on a regular basis, whether it be for our E&Ms, for our CMT codes. We want to make sure that we're billing exactly for the services that we're providing. So let's talk about an example here. And this is an example of a doctor who is in my home state of Florida, and he practices in an area with a very high Medicare population. And some of you who don't practice here in Florida might say, well, I thought everywhere in Florida is. No, not necessarily the truth. I practiced in South Florida, a city called Coral Springs. And while we were surrounded with Medicare communities, Medicare in my practice was less than 10% of my total patient base. So in talking to this particular doctor, he hired me to help coach his practice and build it up and make it more profitable, a lot of the common things that people hire me for. And he mentions in passing in one of our very first coaching calls that he bills a 98941, all right, a 3 to 4 region adjustment 100% of the time. And whenever I hear that something is 100% of anything, that makes me a little bit nervous. So I said, you know what, before I render any type of an opinion, let me take a look at your documentation so I can see what it is that you're documenting and maybe what you're doing in terms of 98941 100% of the time. That's absolutely appropriate. But if it's not, we need to take a look at that and decide what we need to do. So upon reviewing, I found that almost 100% of what he was documenting qualified as a 98940, a 1 to 2 region adjustment. So I asked him, I said, what's your rationale for billing a 98941? And he said, well, he's a full spine adjuster. I said, great, me too. I said, but why are you billing a 41 when you only have medical necessity for 40? So as an example, if he indicated the patient is suffering with headaches and neck pain, well, that's going to give you medical necessity to adjust what? The cervical spine and maybe the upper thoracic spine. That's 1 to 2 regions, 98940. He needed to consider that anything else that he's adjusting, that maybe there's subluxation or segmental joint dysfunction or whatever it is that you like to call it, if it existed in other parts of the patient's spine, that might be considered a wellness service and not something that's therapeutic. And I understand we can talk philosophy, but on a CMS 1500 form, there's no box that you can check off to indicate what your chiropractic philosophy is. So what we need to do is consider what part of the service that we're offering is therapeutic, therefore medically necessary and billable to insurance, and what part of that service might be wellness and therefore not billable to insurance and likely payable through cash. So what did we do? We had to institute a compliance log. This particular practice did not have a compliance program in place. And so one of the things that I'm often asked to do is to assist practices in putting together a compliance program. So we created what was called a compliance activity log, which outlined exactly what it is that we found. That he was doing 100% of 98941s. We found that it should have been 4Os, and that moving forward, he is going to be coding things correctly. And due to the size of his practice and the number of incidents that this created, one of the things that we did is we I would just have him enter that in his compliance log, stick it in his compliance manual, train his staff on it, everybody signs off on it, and we're good to go. But something about this said, we need to do something a little bit different. And what I had him do is to have a copy of his compliance log notarized, make a photocopy of that. He put the photocopy in his compliance manual, and he sent the original to himself, certified mail return receipt. Told him when he gets the envelope back, do not open it, because that way you can prove that whatever is in the envelope was placed in there on the date that it was that it says on that compliance log. And then we also paperclipped the green postcard that came back with it. And I told him, put it in a safe place and let's hope that you never have to worry about it again. But his fun continued. And about 6 months later, he, after he's corrected all of his coding practices, he got what I like to refer to as a little love note from Medicare. And what they did is they asked for a small sampling of some specific patients within a certain date range. And as you might expect, Medicare found what I had found because the date range predated the time that he had corrected everything in his office. So what they did is they took a deeper dive. They requested 100 patient files. And what Medicare is able to do is to do something called an extrapolation. And what they did is they assumed that if they found a 100% error rate with his 98941s during the time frame that they looked at for those 100 patients, that they're going to assume that you did this for all patients. And they could have gone back as far as 6 years. The good thing for him is that because he showed that he was taking a proactive approach, had fixed this error prior to Medicare doing its own audit and investigation, they looked very favorably upon that. So they could have asked for a full refund on everything. They only demanded the difference between the 98941 and the 98940, which for him, in his practice, still amounted to $250,000. But because he did this proactively, he was able to negotiate a 90% reduction in his penalty. So he only ended up paying only $25,000, which was still not a happy day, but did not put him out of business and was a whole lot better than having to pay back $250,000. So be aware that the codes that you use today can have a very real impact on your practice, even years down the road. You need to make sure that we're taking that into consideration. So let's take a look at some of these CMT codes. Prior to the mid-1990s, we as chiropractors, we only had one code that we can use. And for those of you who are veterans like myself, you might remember the code A2000. And you might even look at that and say, hey, that doesn't even look like a CPT code. And you'd be right. It's a HCPCS code, right? And we had one code to describe what it is that we did. So if you just toggled the patient's atlas, or you cavitated every joint from cranial sutures down to the patient's pinky toes, it was still that one code. But one of the great things that happened was in the mid-1990s, Medicare helped us to institute the current set of CMT codes. And as we know, the 98940, 1 to 2 regions, 98941 is 3 to 4, the 42 is 5 regions, and we even have the extra spinal adjustment 98943. All right, remember that the 98943 is only billable once per calendar day, regardless of how many extremity joints you may have adjusted. So we take a look at this and we can say this is pretty easy. But give something that's somewhat easy to chiropractors, and as a profession, let me tell you, we can really do a job at messing things up. So when Medicare instituted these, they expected a certain frequency that these codes were going to come back. Now, this is not written in stone. You're not going to find this as a rule anywhere. This is just what the expectation was. So the expectation is that about 35 to 40% of the time, what we do as chiropractors will probably constitute a 98940. Somewhere between 45 and 55% of the time, the average chiropractor will be doing a 98941, and a 98942, a 5-region adjustment, very, very minimally done, typically around 5%. So one of the things that you want to do is take a look and see, how do you measure up compared to your peers? You know, if you're very high with one of these codes versus some of the others, it may cause you to take a look and see, what are you doing in your documentation? And maybe you need to be doing your coding just a little bit differently. So something to consider in that regard. So the amount that you vary from these expected norms can likely raise the incidence of you getting your practice looked at and audited. So let's take a little peek at a typical practice. This is an imaginary practice. And this particular office, this is their summary of their CPT code utilization from the month of September back in 2017. And you can see that this particular office did 65 98940s, they did 342 98941s, and they even did 244 extra spinal adjustments. They did 16 new patient exams, and then there's a bunch of other codes that they put in there. And you can look down at the bottom of the list that they actually did 2 re-exams. So to me right there, that it will indicate that this practice is either losing their patients before the typical patient is able to have their first re-exam, or this practice might not be doing examinations with an expected frequency. So let's take a look and see what it is that we can do with this information. So in the course of this sample month, a total of 415 adjustments were performed. 73, or about 17.6% of them, were 98940s. 342, or 82%, were 41s, and no 98942s. I don't have any issue with the 0 98942s. But this practice is, based upon what we now know, may be at an increased risk for an audit, as it's a statistical outlier with respect to its 98940s and 98941s. Is that a problem? Not necessarily, if your documentation supports the level of services billed. And that's the key. What does your documentation say? What are your diagnoses? And what are you documenting in your ordinary routine SOAP notes? Statistically, on the 98943, our extra spinal adjustment, I expect that to appear somewhere around 20 to 25% of the total number of adjustments that are performed. Maybe it's going to be a little bit more. As Christy mentioned at the beginning of the webinar, I'm a certified chiropractic sports physician, and it was not uncommon for me to take care of athletes that might not have had a spinal related condition. And I was only adjusting their extremities. Or maybe we were doing extremities in conjunction with a spinal adjustment. That's great, but it's something that we need to make sure that we're aware of as we move forward, because it could indicate a problem for me, because my incidence of 98943 is going to be way higher than 20 to 25%. So with 415 spinal adjustments, I would expect, using that 20 to 25% range, that somewhere between 83 to 104 units of 98943 were performed. But here in this particular practice, he did 244. That's almost a 59% incidence rate. So this practice too may be at a higher risk for an audit, as their rate for 98943 is 2 to 3 times what might be expected from practices that could be considered his peers. So it's not a problem unless there's no extremity diagnosis and if that 98943 is not linked specifically to an extremity diagnosis. So what does that mean? Make sure that you're very adept at diagnosis linking. Yes, it can be a little bit of a process. Yes, if you're not doing it currently, it might be a bit of a pain to do. But it is a very significant compliance-related activity for you to be able to link a specific CPT code to the diagnosis for which that CPT code was done to create a therapeutic effect. So if you put down a patient had a condition in their right knee, but you link that 98943 to all the diagnoses that this patient had, and the patient's also being treated for their headaches and neck pain, while I can certainly argue that closed kinetic chain, again, we can't argue that on a CMS 1500 form, so learn how to unlock the default for box 24E, which says diagnosis linking, and only link your 98943 to the patient's extremity diagnosis. So let's move along. Let's take a look at E&M codes. This practice saw 16 new patients during this month. 100% of them received a 99203 level of E&M. Again, 100% potential red flag. Additionally, the practice saw 415 patients. That translates to a patient visit average of 25.9, meaning that the average patient was seen in this office for an average of almost 26 visits. So that means that we would expect to see approximately 2 established patient E&M codes for every 1 new patient E&M code that was performed. This practice, as we said before, performed exactly 2 E&M procedures during the entire month, all of which were billed as 99212s. This too may trigger an additional red flag. So what is the incidence? Now keep in mind, this is data from 2019. So we can see here that I have 99201 as highlighted. So according to Infinity, which is one of the largest healthcare clearinghouses in the country, many of you maybe even use Infinity as a clearinghouse for your billing. So in 2019, their data said that about 14% of the time, doctors of chiropractic were doing a 99201. We know that on January 1 of 2021, 99201 went away, so that no longer exists. 37% of the time was a 202, 46% was a 203, about 3% was a 204, and a very minuscule amount of 205s. So again, great exercise for you to do. Take a look and see how your practice measures up. Again, if you're viewing this webinar in 2021 or beyond, obviously 99201 should not exist any longer. So why do we want to do re-exams and why do we care? So ask a group of chiropractors and why they do re-exams, and they're going to tell you that they don't do re-exams very often because they don't get much information from them. That might be true. It might be true that you don't do a re-exam to determine if a previously positive orthopedic or neurological test is now negative, but it misses the point. Keep in mind, in the world of third-party reimbursement, we're functioning in a medical model which places a lot of emphasis on those E&M codes. You know, we're dealing with the medical profession who primarily do bill E&M codes as the foundation of their billing procedures, and that their treatment is what? They prescribe a bottle of something, or they refer out, or they cut something out of you. Billing for periodic chiropractic E&M codes keeps chiropractic more on par with the medical professions that are also dealing in the world of physical medicine. So that's one important reason why. Billing an E&M code also creates an electronic event at the insurance company telling them that you are, in fact, evaluating and managing your patient's condition. It's a way for us to tell them that we're not just having the patient come in visit after visit and popping high spots or cracking their back, that we're actually doing something to determine how we're moving forward with this patient's care. So if the value of the E&M is not always on the exam results, why should we do an E&M? Couple of reasons. Number one, we want to use our E&M procedure as an opportunity to hit the pause button and consider, that's why I have this word consider underlined, consider updating the patient's diagnosis. Take a look at what your working diagnosis has been and ask yourself, is this still the right diagnosis to be using for this patient? Then we want to use this time as an opportunity to update the written treatment plan. When I do compliance reviews for doctors so that they can get a better idea as to how good a job they're doing with their documentation, one of the first things I look for is to see, do they have a written treatment plan? And oftentimes, if one exists, it's for the very first round of care. Oftentimes, we do not see that doctors update it. So make sure that we utilize our re-exam time as an opportunity to update the written treatment plan to determine what the patient's course of care is going to be. And then we want to utilize this as an opportunity to update the patient's appropriate outcome assessment tool. Things like the revised oswestry or the Roland Morris or the neck disability pain index. There's dozens and dozens of them. We want to make sure that we implement one at the very beginning of care, either on visit 1 or 2, and then we have them update that same outcome assessment tool on an ongoing basis at each re-exam. So as it says here, tremendous compliance implications are going to come into play here, and valuable information on how we're going to be able to educate our patients and communicate the necessity of care beyond pain relief can come out very much from those periodic E&M codes. One of the things that we want to do as well is we want to systematize our practice. In today's healthcare economy, there's always this push towards greater efficiencies. And creating systems allows us to be more efficient and also help improve our bottom line. Implementing systems doesn't mean that we're going to be cookie cutter. Creating systems allows us to take a look at the totality of what we're doing in our office and apply it to patients who need that care. So instead of baking a new cake every time the patient comes in, we merely just cut off a piece of that cake so that the patient finishes that particular cake once they've completed that particular phase of their care plan. So instead of baking a new cake each time the patient comes in, you just give them a slice. Some people can get a big slice and can move through that particular segment of their care more quickly. Other patients, they might get a little smaller slice and they're going to move a little bit more slowly through that care plan. But that's an important concept to keep in mind. So chiropractic, we think, is pretty simple. About 90% of what we do is limited to about 24 or so CPT codes. So with that in mind, it should be pretty simple to design a recipe for your favorite cake or care plan, so to speak. So what you can each do is take a look at what your menu of services is, or maybe consider what your menu of services that you'd like it to be, and then design a textbook perfect care plan around that. You might even want to have several standard care plans that can vary depending upon the nature and the severity of the patient's condition, the age of the patient, any comorbidities that might exist, etc. And then you can progress your patient through their care plan based upon their response to care. That if this sounds like what appears to be the outcomes-based practice, that's exactly what this is. Most patients are going to end up with a little bit more or a little bit less care than you anticipated, but the expectation in mind is that the patient's care is going to be more of a process that takes place over time and not an event that's going to take place like we're flipping a light switch. So let's continue with this particular practice. So if we look a little bit further, where might there be some missed opportunities? So if it were not for the fact that this one practice actually did one single laser treatment, I might think that this practice was what we once referred to as a straight practice. But there were no therapies, there was no active care. And for an average practice, in a perfect world scenario, if one should exist, and I know that perfect world likely doesn't exist, I often look for 2.5 units of 9/7 XXX codes performed for each adjustment that's performed. So again, what does that mean? It means that for every 98940, 41, or 42, I would expect to look for, in a perfect world, 2.5 units of codes that start with 9/7 or therapy codes. So let's say that in this particular practice, only half the patients that this practice saw, half of the 415, actually required some form of therapy. Maybe the other half were wellness patients. So 207, which would represent half those patient visits, multiplied by 2.5 units of therapy, would mean that I would expect to see 517 units of therapy where 0 existed. So what does that mean? If this practice performed and billed for the 517 units of therapy and an average charge of, let's just make up a number and say $40 a unit, This would translate to an additional $20,680 of additional charges and bring the total charges for the month from $40,635 to $61,315. Given that this particular practice appears to have a collections ratio of about 45%, which in my mind, that's not too great. Good practice should have, at least in today's day and age, collections rate of 60%. That's 60% of your gross charges before write-offs. That would mean that this particular practice, even if we left their collections rate exactly the same, that's an extra $9,300 a month in collected dollars during this particular sample month that we're looking at. Over the course of a year, that's an extra $111,000 in collected revenue. So how much these extra services might help in the clinical outcome of a practice, there's definitely an argument to be made for that. So consider for your own practices how much you might be literally leaving on the table in your own practice. So how can we make use of our EHR systems to help us with these audits? Well, most practices in this country today are utilizing some sort of an EHR system. Whether you're using it for your documentation or not, doesn't matter, but a lot of us are utilizing computers to help us with our billing and coding management. So make sure that you take a look at what you're actually billing so you can identify where leaks might exist in your bucket. It's easy to see that even in an average practice, such as the one that we were just looking at, very meaningful gains can be made if you only know how to look at your data. I've never found a practice where we couldn't harvest some diamonds that were literally hiding in plain sight. So shifting gears a little bit, let's talk a little bit more. We touched on some of the coding changes that took place here in 2021. The easiest one, as we said, was 99201. It's been deleted. So now 99202 is our new lowest level E&M code. So let's take a look and see what other new things we have. So what's not new is the definition of a new patient. That's still the same. And a new patient is one who has not had any treatment or any care in your practice, and the practice is defined as your current tax ID number and your current NPI number for your practice during the previous 3-year period. A previous patient who presents to you 2 years and 11 months since their last visit is going to be treated as an existing patient, and for that patient, you're going to be billing it as a 9921X, not a 20X. If the patient came in longer than 3 years later, then we can treat them as a new patient again. So we need to go through quickly some vocabulary. I want to make sure that we save some time for some Q&A. So I'll put my email address up again later. So if you want to get these definitions and have them on hand, I'll be very happy to send you these notes so you can have all the verbiage. So a problem actually has a specific definition. It's a disease, condition, or illness or injury with or without a diagnosis being established at the time of the encounter. A problem that's addressed is a problem that you're going to deal with. So notation in the patient's medical record that another professional is managing that problem without additional assessment or care coordinated with that provider, it does not qualify as a problem that is addressed by you. So you're treating a patient for headaches and neck pain. The patient happens to mention that they have an ingrown toenail. Obviously, as a chiropractor, that's outside of our scope. You're going to refer it out to the patient's podiatrist or primary care doctor to get that taken care of. You would not consider that as a problem that has been addressed. Minimal problems are ones that are self-limiting. A self-limited or minor problem is one that runs a definite course that is transient in nature and is not likely to permanently alter the patient's health status. We have acute, uncomplicated illnesses or injuries. These are recent or new short-term problem with a low risk of morbidity for which treatment's being considered. There's little to no risk of mortality with the treatment, and full recovery without functional impairment is expected. An acute illness with systemic symptoms is an illness that causes systemic symptoms and has a high risk of morbidity if we don't treat it. An acute condition that is a complicated injury is one that requires treatment that includes evaluation of body systems that are not directly part of the injured organ. The injury is extensive and or the treatment options are multiple and could be associated with the risk of morbidity. So an example might be a head injury with a brief loss of consciousness. And what does morbidity mean? It's a state of illness or functional impairment that's expected to be of substantial duration, during which time function is expected to be limited. Quality of life might be impaired, and there may even be damage to the injured body part or organ that might not be transient despite treatment. So let's take a look quickly at this particular chart. We can see here that we have listed our established E&M codes and our new patient E&M codes. And you can see at the top line, there's only a 99211. Why? Because as we said before, 99201 has been deleted. And you can see here that there are no minimum requirements for levels of medical decision-making, no issue related to the number and complexity of problems addressed, etc. for a 99211. And why is that? 99211 is not considered to be a doctor level code. So if you as the doctor had anything to do with that E&M procedure, we would automatically use a 99212 as our lowest level established patient E&M code. For those of you that may have a multidisciplinary practice, if you have, let's say, a medical assistant that does a blood pressure check, maybe your medical provider is managing the patient for hypertension, changes the medication, and we want to see how the patient is doing on their new hypertension medication. Great. Patient comes in for a blood pressure recheck. That is a perfect example of a 99211. Your medical assistant took care of the patient's blood pressure. A physician level provider was not involved. A 202 or a 212, medical decision making is considered straightforward, and we're dealing with one self-limited or minor problem. 203 or 213, we're dealing with low levels of clinical decision-making, two or more self-limited or minor problems, or one stable chronic illness, or one acute uncomplicated illness or injury. 204s are going to be more moderate, and we're going to be dealing with one or more chronic illnesses, two or more stable chronic conditions, or one undiagnosed new problem with an uncertain prognosis, or one acute illness with systemic problems, or one acute complicated injury. We can go on and look through all this, but I don't want to spend too much of our time because there's good news in all of this. And that good news is that now time may be considered a determining factor in our ability to select E&M. Now, once upon a time ago, time was considered a factor or considered an other factor in how we determine E&M codes. How we're going to be counting time now is going to be very different, and it's going to be very different in my opinion, a very good way. What is considered time? Time now is going to not just start once your eyeballs as the patient's healthcare provider are now on the patient. Our time now starts to tick as soon as your eyes hit the patient's intake paperwork. So patient fills out their intake papers, you got to review that. You can now get paid for that time. The time is going to continue if our patient has brought with them any outside lab work or imaging. All right, so how many of our patients bring x-rays or MRI reports or CDs or actual films, maybe lab tests that were done elsewhere, maybe even treatment notes. You need to review that. You can count that time. Your time is going to continue when you do your consultation, and it's also going to continue as you move forward into your exam. Once you finish your exam, then you may, for those of you that are taking x-rays in your office, you may decide that an x-ray might be appropriate. Time does not count. We stop the time when we go to take x-rays. Why? Because those x-rays are going to be billed as a separate and distinct procedure. You bill separately for your x-rays. Maybe you're going to do some form of treatment on that very first visit. Great. We're not going to count time at all there either because those services will also be able to be billed separately. However, we can start counting the time again when you start to do your notes in your EHR, or if you're doing paper notes, that's also still acceptable. You can start counting time again when we put into place your treatment notes, provided that the notes are done on the same day as the encounter. Is it okay to save your notes for the next day? Well, I guess, yes, it's okay, but you cannot count that time towards total treatment time because the notes have to be completed on that day. So maybe this, for some of you, is an impetus to get your notes done in a more timely manner because you are now going to get paid to do your notes on time. Happy day. So if the patient has total time spent with you between 15 and 29 minutes, that's going to qualify as a 99202. A 99203 is between 30 and 44 minutes. A 204 is between 45 and 59 minutes. And I included here a 99205, but as we said before, this should be done very, very seldom, if at all, 60 to 74 minutes. For an established patient, we also have time components. The times counted are a little bit different. And as you might expect, 99211, because it's not a physician level code, there is no time factor taken into consideration here. 99212 is between 10 and 19 minutes. 213 is total time between 20 and 29 minutes. And a 214 is between 30 and 39 minutes. You can also consider a 99215. That would be between 40 and 49 minutes. But in a typical chiropractic practice, that should be done very seldom, if ever. So this is a really nice change that has taken place in the world of coding, in my opinion. So what do we want to do? We want to make sure that we're keeping our eye on our EOBs. Whenever there's been changes, especially related to E&M, many insurance carriers might utilize this as an opportunity to deny or downcode your E&M procedures. Why? Because they know that most physicians and even many billing managers are not really up to speed on why a particular level of E&M is selected. So one of the things that I want for you to do is to make sure that you document your total time spent in the plan portion of your notes so that we now know exactly why you selected the particular level of E&M that you did. So in the case of E&M codes, be aware of those automatic down codes. Here, the insurance carrier may downcode your E&M by one level in the hopes that your practice might not notice, or you might not think that it's important enough for you to rebut. Don't let them do this to you. Even though it might only be a few dollars in difference of reimbursement, if you come back and you rebut and show them that you understand why you picked a particular level of E&M, eventually what will happen is that information will hit your profile and they will not hassle you any longer. They're going to pick on other practices who might not be up to speed on why they particularly picked a certain level of E&M. Know what constitutes medical necessity, not just for your E&M, but for all your codes, so you can appeal any unrealistic denials and downcoding. So I want to shift gears just a little bit, and I want to make some of us aware of some of the pitfalls and landmines that we have to avoid stepping on in our world in healthcare today. And chiropractors, to our credit, we are amongst the most entrepreneurial of all healthcare providers. And this has been generally a good thing for our profession. You know, at times, however, this entrepreneurial spirit, it gets the better of some of us. And sometimes people might be tempted to cross that fine line between what is black and what is white, and they enter that gray zone where they don't want to be. And during challenging times, many people might be looking for new ways to increase their market share, increase profits, or maybe even just to utilize some of these things as an opportunity to stay afloat. And while some of these things might be tempting and sound completely legitimate, and some of them from a clinical perspective are totally legitimate, be aware that some common things are out there that can trip up an otherwise great practice and put your life's work literally at risk. So most important one is this, and that is don't take coding advice from equipment vendors. Now, some of you might be listening to this and say, well, that sounds like a no-brainer. I'm going to tell you that they make it very tempting. Most reputable vendors have nothing but your best interest at heart. They invest in building relationships with you, their clients, and they want to serve your practice and develop a long-term relationship. But there's plenty of others out there that are out to make a quick sale. And some may tell you that their product can be billed using certain codes and that might be paid at certain extraordinary levels. Keep in mind, once the sale's made, they may not be there to support you if things go sideways. You ultimately are responsible for the codes that you bill, and the risk is on you. So I'd like to share with you an example that's happening right now. So I'm working with a doctor in Illinois. No, not really, but I want to change the names to protect the guilty here. This particular doctor has a multidisciplinary practice, and he's got a chiropractor, a nurse practitioner, and a medical assistant on staff. This doctor has a friend who practices similarly, but in a different state, and that friend told him to call a particular company to get a certain machine that treats condition X. And I don't want to mention condition X because I don't want to create a storm of controversy here. Because if I mention what the condition is, many people I'm sure are going to be very aware of what I'm talking about. Let's keep it anonymous for now. You get the idea. He said you want to get this one machine because he's collecting over $5,000 for each patient, and insurance, including Medicare, is paying for everything. Sounds really tempting, doesn't it? So the doctor in Illinois contacts the company. He's intrigued. The clinical results are indisputable, and patients are getting well. And it's true, patients are getting well. The billing and coding for this particular procedure is actually quite complex. So the equipment company created a relationship with the billing company so that all the clinics utilizing this equipment and are going to know exactly what needs to be done with the associated protocol. And all those clinics have to do is tell the billing company who they treated on a given day, pass along that patient's insurance information, and the billing company is going to do the rest, which sounds really sweet, right? Until there's some breaks in the armor. First break happened when patients started to get their EOBs, and they're starting to see charges of between $8,000 and $12,000 for each date of service. Now, we all know that what you bill and what you collect is totally different, but when patients start to see dates of service in that range, can freak some of them out. And total charges can easily exceed $75,000, in some cases over $100,000, more than a stay in the hospital. So word starts to get back to many of these patients' insurance carriers from shocked and worried patients, and the record requests, as you might imagine, start to come in. So they are asking for a review of the billing and the associated documentation, and some of the codes are absolutely legitimate. Maybe they're inflated, maybe they're happening a little bit too frequently, but they're legit. Other codes are being billed but can't be justified as having been performed at all, and others are being performed, but they're not being performed within the definition of medical necessity. It sort of looks like it, but when they start to look at the notes, it becomes very obvious to anybody that the level of medical necessity is not being met. So what happened here? When asked why certain codes were being billed by me and the insurance companies, the doctor had no idea. And he stated that the insurance company and the billing company had it all worked out, so that all he had to do was get the patient's information and provide the date of service, and he's good to go. So I'm helping this doctor out because I definitely found a significant compliance-related issue here. So we scheduled a conference call with the billing company to inquire why some of these codes are being billed without any documentation of the service being performed. The account rep at that billing company seemed not to understand coding 101. He's like, I don't know why that was billed. I just do what I'm told to do. Well, thank you for sharing. Let's move on. So I asked for the owner of the company. And the owner of the company stated that if the doctor didn't want a code to be billed, he should have told them, which might be true, but they're being told that this is the protocol. And that also is not the right answer. Granted, the doctor is ultimately the one responsible. So where is this happening now? Surely he's not using this billing company anymore. To date, over 50 records have come in from all different insurance companies, including Medicare, and he's getting several more requests each and every week. He had no compliance program in place to minimally show that his practice's intent is at least to do things correctly, which could have been something that he would have been able to use as some sort of a defense. So he's hoping that by taking some proactive steps before these follow audits began is going to be of some help, as it was for that doctor in Florida that I mentioned in the earlier case study. But he is preparing for the possibility of a mid-six-figure refund back to insurance carriers as a possible worst-case scenario. It is entirely possible that things can get much, much worse. My hope is that the auditors at these insurance companies are going to realize that this doctor, is in addition to a whole bunch of other doctors that are caught up in this whole thing as well, that they will see that they are merely pawns and that they're really going to be looking to follow the money trail and go back up towards the billing company or the equipment vendor themselves. How it plays out, we're going to remain to see, but this is definitely in process now. So moral of the story is know what you're billing at all times. Make use of your software to know what's being billed and what's not. Take a look at how your practice may appear in a possible audit. How different is your practice compared to your peers? If you're very different, be ready and able to justify that difference. Being different is not a bad thing, so long as you can justify it. And don't be lulled into promises of easy riches. All of that and more can evaporate if your billing, your coding, your documentation, and medical necessity are not all aligned. It's easy to do things correctly and get paid well. And if you need help on how to do it, just ask. So as I said before, if you'd like my notes for this particular webinar, please be my pleasure. Send me an email to drjefflewin@gmail.com. I will be happy to email you the notes for this presentation so you can have all the details, all the wording that constitutes the definitions that we discussed before, and it would be my pleasure to do that. When you're emailing me, please make sure that you reference this ChiroHealthUSA webinar on documentation and coding. I'll be happy to send it to you. So lastly, before we wrap up, invariably whenever I do this, there's people that have questions. If you have questions, if you have concerns, this is what I do for a living. I am a chiropractor. I take care of doctors all over the country, so I'm happy to help you out, whatever your concerns might be. Feel free to give me a call. 954-205-3479 is my cell phone number. I do answer it. And you can also send me an email. I'll be happy to make a time so we can meet privately by phone to discuss what your questions and your issues happen to be. So, Christy, that's our webinar for today. I know that I see there's a lot of people participating in our webinar, and be happy to entertain any questions that maybe have come up during the course of the webinar so far.
So we don't have any questions. We had a lot of people who said, thank you for this great information. So
awesome.
I have posted your email address, I can speak, in the chat box so everybody can request the handouts. And again, reach out to Jeff if you have any additional questions afterward. He has been kind enough to give you his email and his phone number so that he can answer your questions, especially if you have those questions you don't really want to ask openly, even though you can message me privately and we can open, I won't say your name, but if you, because this is the kind of silence, but if you do have questions that you just would prefer to ask Dr. Lewin directly, then feel free to reach out to him and get his advice, because he's got great advice.
And I'm happy to help in any way that I can.
So I'll give everybody just a minute to type in any questions. And I did see, so a couple of y'all are from Florida. So
yay, Florida.
Yeah, he lives in Florida himself, but he will be speaking in Miami at the next FCA event on June 23rd, 24th.
Yeah, I think it's the last weekend in June.
Yep, I should
right.
know.
Yeah,
I'm gonna be there. It's my son's birthday weekend that weekend, so he's probably coming with me. And of course, his birthday is Saturday, but I'm speaking from 8 to 5 on Saturday.
Of course you are. Well, you'll be in Miami. You'll have the opportunity to take him out and make it up to him as well. And it's a beautiful resort down in Miami at the Trump Doral. So if anybody who is interested, whether you're an FCA member or not, FCA puts on awesome events. The FCA has done a great job, even in the world of COVID. They've figured out the great recipe on doing a hybrid event, so you can come live, and it's great. It's safe. It's socially distanced. I know, Christy, you and I have spoken at 4 or 5 of them together over the past several months, and which is great. And they also broadcast them virtually. So if you're either unable to attend live or choose not to attend live, you can attend virtually and have that same experience. And it's also highly interactive. So you get that opportunity as well.
It absolutely is. And I was looking to see what webinars were coming up next. And actually, everyone that is speaking this month will be in FCA, Miami, Florida. I wonder where it is that I meet all these amazing, brilliant minds in chiropractic. So next week is chiropractic is brain-based healthcare with Dr. Michael Bagnell, who is also from Florida. And he is just positively brilliant in the work that he's doing. So phenomenal. And then we will be wrapping up the end of the month just before Memorial Day with my dear friend, Dr. Cindy Howard out of Illinois. And a lot of the speaking that I'm doing on Saturday is in her panel discussions.
Yes. Do you want to tell what the topic is too?
I don't. In all fairness, when I agreed to do that, it was before I knew what. But she and Jen asked me, they're like, "You want to have some fun?" And I said, "Of course, with you too."
Yeah, they're talking sex.
Yes, it's about sex, believe it or not. And I was like, "I'm not a doctor. I can't talk about this." So I said yes, then I said no. And then they were like, "No, we don't need a doctor. We need somebody who talks about the rules and to talk about the non-clinical aspects." And I was like,
That's right.
Okay. And I wasn't supposed to do that till Orlando, but now I see I'm doing it all over Miami.
Awesome. Great dress rehearsal for Orlando.
Yes, it is. Yes, it is. So, but she's actually going to be talking about the ABCs of your practice: adherence, brilliance, compliance. It's a lot about communication. So, which she's really good at talking about.
Oh yeah.
So we have a really exciting lineup, and we kicked it off with some great speakers, because last week we had Mark Abla, who's also speaking in FCA on the Cures Act. I just saw when I was looking at the calendar. So apparently the month of May is highlighting all of the speakers who are going to be at the Florida Chiropractic Association convention in Miami. And probably, I know Jeff and I don't know about Mark, but the rest of us will all be at FCA National as well in Orlando and August.
Yep. I will be there.
We will. So if you want to hear this live and in person and get down to the nitty-gritty details, join us in Miami. We would love to see y'all. Seriously, we would love to see y'all. So I don't see any more questions. But thank you so much, Dr. Lewin, for making time in your busy schedule to hang out with me today.
My pleasure. Thanks so much for the opportunity, and look forward to joining you again in the future.
Absolutely. Okay, everybody, y'all have an amazing rest of your day, a fabulous week, and I will see y'all next Tuesday when I introduce y'all to a first-time presenter on our webinar series, Dr. Michael Bagnell. And he is going to blow your mind literally with all of his stuff. And I know we're talking about brain-based healthcare, but I promise you it is so fascinating and not like big words over the top. I'm talking, even I understand it. And it, like I said, blows my mind every time I have a conversation with him. And his beautiful wife, who has been a presenter multiple times, May Bagnell. So guys, have a great day. Be fabulous. Be awesome. Work miracles. Tell me all about them next week. Bye, y'all.
Bye now.